For us, when we were developing the business case, a big driving factor was that we had medics and nurses that were working throughout the county, covering multiple services, but struggling to get to those services to prescribe and review patients. So by deploying e-prescribing, we knew that no matter wherever they were in Leicestershire, they would have access to electronic prescribing, and they could review patients' prescriptions, provide consultations there and then without having to physically go on site every single time, ultimately improving patient care. The Mental Health Act is complex, to say the least, but it's important that when replacing an e-prescribing system, we still give the same information we would have given to the nurse or the prescriber at the point of administration. So they need to see the Mental Health Act. So we had to think, okay, how are we going to manage this? So we took the system and we mapped out our current process and thought, okay, so we need to give the information to the Mental Health Act team. We need to have a good flow of information between the prescribing team, the pharmacy team, and the person that's administering that medication. So we came up with a concept using the patient notes. We build in the T2 and the T3 forms for mental health onto the system, and we populate the data. So at the point of administering, which is the important part, the nurse is able to review that T2 and T3 and ensure that they are making sure they're sticking to the regulations that have been imposed on that patient for their care. It gives us a more accurate, up-to-date reflection of what's going on in the Mental Health Act because all teams can see it. The Mental Health Act office can also review those notes. They can input, they have access from their offices as well. And as soon as something changes, it gets sent through to our team, we update those forms and we give the information to them live. So at the next drug round, they'll see what they need to do. We went to London to do a conference and do a presentation on e-prescribing, particularly around mental health and how we deployed it. And during that presentation, the medical director from Nottinghamshire Healthcare Trust approached us about e-prescribing. He's very excited about what we'd done. So they were looking at us to kind of guide them in what we could do. So we followed that up with some meetings and we decided to kind of present a business case to them and say, look, we'll support it. We'll do the project management for you. We'll do the day-to-day training for you. We'll go out there, we'll do all of it for you, and we'll deliver it on a system that we've already got built that works within a mental health arena. We've already done this model before, so it was just about deploying the model of e-prescribing again to another trust. And it went through and there was no issues, no delays, no prescribing problems. The database was perfect for what they needed. And they felt they had a real input into something because they could focus more on what needed to be delivered as opposed to worrying about the business aspects of the project.
They would be on a geographical location spread across the city and the county, so people were having to drive half an hour, 40 minutes, maybe longer to reach a particular area. And with a drug card environment, they might do that drive and then find out the drug cards were unavailable because another professional was using them for a particular purpose, and that was just wasted time. Whereas now, any desktop that you put JAC EPMA onto, then that practitioner can access prescriptions. And I think one of the things I particularly like about it is that means you don't have to do everything in a big block. You can sit down and I think I've got a 15-minute window, sit down at your computer, you're immediately onto that patient's record, you can probably review 2 or 3 patients, you've got all the information you need. Every time we see a prescribing error, we put that into our e-prescribing team and see what we can do to potentially tweak the system to mean that error will not happen again. Now, as a very straightforward example of that, there's a drug called a nitrate which has to be given twice a day but must be given morning and lunchtime, which is a rather unusual kind of regime. Most twice-a-day medications are morning and night. So before we had EPMA, most of our junior doctors who are not experts in physical medication would always write up the medication morning and tea time or morning and bedtime. Now that actually means for that particular drug that it will stop working very quickly because the body will get tolerant to it. Now with EPMA, we could see that prescribing error was happening on a regular basis, so we then set up something in the system which automatically tells the doctor, to prescribe that medication morning and lunchtime. Now since we built that into the system, we've never had an instance where somebody's nitrate has been prescribed inappropriately because the system supports them doing it.
The best part for me, and I get quite excited about, is the fact that we can report on anything. You know, the data that sits in the back of that system, unlike many other suppliers who aren't so free about their data that we're collecting in the background, we have full access to data. And we've done some quite clever stuff with reporting. So an example would be a patient comes in and they're prescribed what we call a rapid tranquilization, something to calm them down quite quickly. When we do that, we're supposed to fill in notes about what's happened, incidents about what's happened, and also follow up on that patient's treatment. We now, as soon as that's administered to a patient, fire off messages to the relevant teams to tell them this has happened, please action. And it means that we can improve and make sure we're doing the right things to improve patient care and doing things the right way as well.
There are lots of medicines-related audits built into this trust schedule of audits that need to go to our commissioners. And when I met with them 2 months ago, you know, they said, your reporting, your work on medicines issues is at a very high level, and that's because we've got EPMA and we can report easily and clearly and succinctly about what the issues are. When they've had it talked through what EPMA does for us and the kind of information that's available, they're very happy that that's a very robust medicines management structure that supports patients and makes sure that practitioners get the advice they need before prescribing medication.
The challenges that we were presented with, we learned from them. And now, because we can guide people and we can give them suggestions about how we've done things and why we've done things the way we've done, I think it ultimately improves their potential deployment of EP, absolutely.